All right, good morning, everyone. I'm Anna Ogina, pediatric hospitalist at A&MC and your AAP Alaska chapter president. I'd like to welcome you all to our Tuesday morning, May the 10th, grand rounds on Pediatric Orthopedics today by Dr. Daniel Brown. But before I introduce our speaker, I'd like to recognize that this virtual Zoom grand rounds is hosted in Anchorage, Alaska, which is the Dena'ina et Nena homeland. This land acknowledgement is to show appreciation for the past and present Indigenous stewardship of the lands where we now live, work, and play. For some housekeeping items, please mute your microphones during the presentation, but we certainly encourage you to turn on your camera and video so we can see each other from wherever you're zooming in from across the state and elsewhere. This Grand Rounds will be recorded for educational purposes and archived on our aapalaska.com website. You are consenting to this recording by attending. And please participate, ask your questions, share your experiences in the chat box. You can also unmute yourself during the Q&A portion at the end. You will be able to claim CME for viewing, attending in real time only. A link will be provided in the chat box so you can fill out the brief form and print your CME certificate. So I'd like to welcome our speaker, Dr. Daniel Brown. He is born and raised in Southern California, but he says not to hold that against him. His high school had a surf team and a roller hockey team, and he still says dude and sweet on occasion. I also do that because my family now has been living in San Diego for more than 20 years. His claim to fame is playing high school basketball in the gym used in the film It's a Wonderful Life. You know, the scene where the gym floor over the pool opens up and they all fall in the water. It smelled like chlorine. He fell in love with the outdoors and mountains while working on a farm and ranch in Idaho, where he also met his wife. His undergrad was at BYU, medical school was at Duke, residency in orthopedic surgery in Fresno, California, fellowship in pediatric orthopedic surgery at Campbell Clinic in Memphis, Tennessee. He began practice here at the Orthopedic Research Clinic of Alaska in 2019. He's recently board certified, congratulations, and he's married with 4 kids, ages 4, 6, 9, and 11. Outside of medicine, he enjoys hiking, biking, camping, and trying to keep up with his kids on downhill and cross-country skis. So take it away, Dr. Brown.
All right. Well, good morning. I'm hopeful you can see the screen here. So I'm using 2 different devices. So if the screen share is not coming through, please someone speak up and let me know. So disclosures wise, can someone give me a thumbs up or a nod that that's working? It's working. Okay. Disclosures. So no financial disclosures or conflicts of interest, other than that YouTube videos about orthopedic surgeons are entirely correct. I highly recommend both these if you have not seen them already. My purpose today is, number one, to report back. I'm in a small group. We're figuring things out as we go. Probably all of you have been there or are there currently. And so there's just a lot of strings to pull and a lot of things to happen. And so I'm not always the best at getting back to referring providers. And so this is an attempt to at least share some of the more interesting cases and report back on some of these, maybe your patients. And also I'm learning that families have lots of different ideas about orthopedic surgery, about medicine, about what timing should be. And so if we can have a little more consistent messaging, I'm not saying it has to come from me, but there are certain things that if they hear it from multiple sources, maybe it'll start to sink in. And then lastly, to improve care for the kids and their families. This is a screenshot of a text interchange I had recently with one of the orthopedic surgeons in Portland at the Portland Shrine. And there are kids that don't need to go out of state for their surgeries anymore. There are some that still should absolutely go out of state for their surgeries. This kid in question is a child with neuromuscular scoliosis, pretty severe, needed halo. That's the frame around the head and then traction. for 3 to 4 weeks, which is just not something we're set up to do here, followed by placement of rangic rods. Now, technically it can be done, but surgery, it's not an individual sport, it's a team sport. And so this was best done there. However, it's burdensome on that family to travel down there every 6 weeks for the lengthening. So I actually lengthened them in clinic yesterday. And so this is a fairly recent thing, and that we're starting to become a little more collaborative, and hopefully we can keep these kids here and as much as possible. So now you see a lot more breadth than I see. And so I'm aware of who my audience is, but I'm not a pediatrician. So if I am not getting the depth you would like to see or hear, please speak up and let me know. I'm fairly pigeonholed in a small niche, but I like it. It's kind of fun. But I do think it's helpful to know when a patient goes to the next provider or is referred to someone else, what are the next few steps? And so that's some of what I'll cover today. Topics we'll try to cover briefly. Sports a little bit, and then growth with its implications as far as leg length and rotational variations and timing of things, scoliosis and other issues about the spine, and then finally everyone's least favorite topic, non-accidental trauma. All right, so child comes in, my knee hurts. First thought that pops into my mind is, how's the hip? Because hip pathology can be felt as knee pain, and just like knee pathology can be felt as hip pain. I've seen it. I've ranged the hip, and all of a sudden it's a skiffy. It's not a knee injury at all. Of those knee injuries, this is just a partial list. And in making this, I've seen most of these here in the last couple of years. There are a couple I know I have not seen here. I haven't seen them since fellowship, but it's a wide variety. So there's not time today to go through all of these. So, and a lot of these are, technical differences that I might encounter at the time of surgery, probably not as applicable to you. So I want to do something we've probably all seen, or have all seen, and that's an ACL injury in a skeletally immature patient. Now, what this picture is, this is from one of the textbooks on operative techniques, and it's an increasing order of increasing age. So A is a young child. This would be, say a 6-year-old, where if the ACL is ruptured, and unfortunately we are seeing this probably more in the lower 48 because there's a little more organized sports involvement there than I think there is here. Fortunately, which I think is a good thing for Alaska. The epiphysis, the ends of the bones, is not very robust, not very strong. There's not a lot of volume to it. And so any reconstruction that's undertaken at this time would be used with the IT band, and it's brought around up over the top of the lateral femoral condyle. It's a non-anatomic reconstruction. You slide it through the notch underneath the intermeniscal ligament, and sometimes you even get it through partial or some of the root of the anterior horn of the medial meniscus, because it inserts fairly far laterally. And then you bring it external to the periosteum and tack it down to the bone. And this actually does very, very well as far as restoring kinematics in the knee, even though it's a non-anatomic reconstruction. These kids do great long-term. As we slide over, B would be a slightly older child, say 8 to 10 years of age, where you now have a little more real estate in the distal femur, and so you can do an all epiphyseal anchor. And so that's going to be a soft tissue graft anchored on the cortex with a button. And then again, you're going to try to do a under the intermeniscal ligament on top of the physis, or external superficial to the physis, then tack down to the surface of the bone. As we increase in age, now we're talking say next 2 years, 10 to 12-year-old. And that depends on where this kid is in their maturity as well. But there's now enough real estate, you can do an all epiphyseal. And moving on over, D is just the next stage where you can now cross the physis, but you're not going to cross the femur. The distal femoral physis doesn't tolerate disruptions or injuries to it as well as most of the other physes in the body. And it's also one that provides the most longitudinal growth, up to about 1 centimeter a year, depending on who you read. And so if we have to violate it, we do it in a physeal respecting way is probably the best way to say it, is you try to be perpendicular to the physis, which is what you're going to see in E. We try to do it in the child who maybe only has a year or two of growth left. They're basically past their growth spurt. And so these are kind of your more high school athletes who are getting closer to skeletal maturity, who are more likely to tear anyways. Now, this doesn't show the wrinkle that we see common in children, which is an avulsion of the footprint of the ACL off the bone. It's not a mid-substance tear. It's actually pulling the bone off the top of the tibia, tibial spine avulsion. It's kind of a pediatric analog to an ACL injury. And so that might be more common in the age range of 6 to 10. And whereas you start seeing the more mid-substance injuries as the kids get older from that. So case example, 11-year-old female comes in. She was a skier. She wrecked, apparently yard sailed pretty good for the mother, and has symptomatic buckling and giving way of the knee. She's now 6 weeks out from injury. And on exam, she's got full range of motion in the knee. The swelling's gone down. You test her ACL, though, with a Lockman and an anterior drawer. And on Lockmans, we grade these 1, 2, 3 in order of how much translation there is. 1 being about 5, 2 being 5 to 10, 3 being 10 to 15 or more millimeters of translation. And it's a feel thing. And then A and B is there an endpoint or not? So 3B, that knee is just loose. It's just sliding forward as it can be. And there's no structural integrity to the ACL. Now, so she's 11. And here are her x-rays. So on the left-hand side of your screen, you have the AP. In the middle, you have the lateral. And on the right, you have the sunrise view. And if you look closely on that AP view, on the lateral aspect of the proximal tibia, you'll see there's a little fleck of bone next to the epiphysis. That's a Sagan fracture. That is pathognomonic for an ACL rupture. Now, what that is there's a little attachment site for a ligament in the knee, your anterolateral ligament, that as the knee slides forward and the ACL ruptures and keeps going, it pops off the attachment point for that ligament. Now, we see ACL ruptures without Sagan fractures. We don't see Sagan fractures without ACL ruptures. So we know that the ACL fails first. And if you see this fracture, then that was a good one. So other than that, her physes, they're open. They are not the most open. And so, other than that, her knee x-rays look fine anatomically. Now, if we go to the MRI, we have a coronal T2 on the far left. We have a sagittal T2 in the middle, and on the far right, another slice of the same sagittal sequence. And on the right, we're looking in the coronal plane. So you see the back side of the femoral condyles, the back of the tibial plateau. You also see a little bit of the fibula there. Now, there's increased signal in that lateral aspect of the proximal tibia. You see how it's brighter on the lateral side than the medial side. If we jump over to the middle image, that's the exact same area of bone, but in the sagittal plane. And so you can see that light area, again, on the back of the tibia, but you also see it in the middle of the femur, the distal femur. Now, when the ACL ruptured, those two areas hit each other. And that's a characteristic bone bruise pattern that we see in ACL injuries. And so that gives you an idea of how much translation there was at the time of injury in this patient. And that's, it's a real bone bruise. Structurally, the cortex isn't broken, but that's a real impact. That's a lot of damage. Then on the far right-hand side, you can see the patella in the front. You can see the femur. You can see the open physes. Now, the patella tendon, see if my mouse shows up, is here, nice and black and solid. Same with the quadriceps tendon, and same with the portion of the PCL that you do see. There should be an ACL here in this slice, and her ACL is essentially exploded. So it is just not. There is no question at all about what her injury is. So diagnosis, ACL rupture. It's an isolated injury. What are we going to do about it? This isn't something we repair. It's a reconstruction. And so because it's a reconstruction and not a repair, we're not as limited in terms of timing. We don't have this window of healing that we have to get in and get to as quickly as possible. Graft choice for this in pediatrics, the gold standard is autograft. It's their own tissue. Allograft is completely inappropriate in a pediatric patient. It is entirely appropriate in select adult patients. Now, our source for graft is usually the same knee, the ipsilateral knee, and it's hamstring. And often we can get away with just a semitendinosis in these kids. If they're a little smaller, the hamstrings, then we may often need the gracilis as well, and we loop them and double them over, and that gives us enough volume to create a strong graft. We can also use a patella tendon. That comes with bone blocks, and we take the middle third of the tendon. Eventually, it regenerates, and they've done studies, and you can actually go back and reuse that tendon as a graft. Now, I don't know of anyone who's actually done that, but the literature states you can. So it comes with bone blocks, though, and so that's our standard for, say, the 17, 18-year-old kid who's a football player, big, strong guy, who's going to be putting a lot of force on it and wants to get back. And so it's a bone block. We don't use that in kids. One, you don't want to put, or kids with open physes. One, you don't want to put a bone block across the physis. Two, you don't want to damage the tibial tuberosity, which is an apophysis. So there's also an option of using the quadriceps tendon that can be with a bone block or without. And that's kind of, it's a bit of dealer's choice. What technique are you most comfortable with in your hands? What's the age of the patient? What are their aspirations moving forward? How's your discussion go with the family? Things like that. Have they had prior surgeries? Now, adults who have had their ACL reconstructed or have had their hamstrings taken for other procedures, I haven't met one yet who doesn't regret having their hamstrings taken. If you're one who has had your hamstrings doing great, please talk to me. I would love to hear your story. Kids don't seem to mind that as much, and maybe they don't know any different. When they test the strength, they get about 80% of their hamstring strength back based on static in the lab tests. Usually there's not a functional difference. And it is the workhorse for open physes in these kids. So basic principles, kind of some general assumptions, and we use this a lot in Ortho for Growth. It's not perfect, but it's fairly accurate. So averages, we say skeletal maturity in boys is about age 16, and girls about 14. And why we get away with this, I think, is limited to, or related to our predictions and our arithmetic method of determining leg length and predicted growth. And I know it's not precise, and it's also an average, but the math usually works out pretty well. So the vast majority of the longitudinal growth occurs about the knee, 9 to 10 centimeters in the femur, 5 to 6 at the proximal tibia, 4 to 5 distal tibia, and then 3 at the proximal. And there are 4 to 5 different methods for predicting growth and skeletal maturity. The reason, because no one is perfect. And so most people use 2 or 3 on the same given patient to say, hey, how mature are they? What is the best intervention for them? Now, so going back to our 11-year-old female, what technique do you want to use? Well, she's kind of, mid-range, all epiphyseal, if we were to look at that, maybe D, maybe a hybrid technique, or E, physeal respecting. Now, she didn't have a ton of growth left on her x-rays, but how about if we add that she's now 9 months post-menarche? And then there's other information that we also may want to get that will help us out. And it's the bone age. And so when you look at her skeletal age, it's a measure of skeletal maturity. It's where is she in her maturation process? And this fits with that assumption that they're done at 14. So skeletal age at 14, these physes in her hand are basically closed. You just go through the atlas and compare. And so she's got maybe a year of growth left. She's through the vast majority of it. She's slowing down. And so in her, I actually recommended a physeal respecting. So one, she's a high, an athlete's putting a high amount of stress on her knee. She's active. You look at her, she looks like a young woman, doesn't look like a girl anymore. She's through her growth spurt, or getting close to be done with her growth spurt. And you get the sense that she's going to test this a fair amount. And so you want good, robust anchors. Now, when we put this graft in, it's actually stronger than the native ACL, and sometimes twice as strong. That quickly decreases though. So by about 6 weeks, that graft is actually fairly weak, and it's the time point when patients are feeling the best. They're finally through the tear, they're through some of the prehab, they're through the immediate postoperative period, and they kind of want to get after it. They're getting a little stir crazy at this point. But we really have to slow them down and say, look, you're just not there yet structurally. And they've done studies that look at the amount and rate of incorporation into the body. And what happens is the body sees the graft, it then slowly recruits cells to form collagen and at the same time break down the graft there. And so the graft becomes more of a scaffold for long-term collagen deposition rather than this thing that's going to last and hold their knee stable for the rest of their life. And so by 6 to 8 weeks is really kind of the weak point, and then things start getting stronger by there. But full strength is not achieved until 9 months to a year. And that's sometimes a hard thing to ask for kids to wait. But if they want to do well long-term, they're going to have to. All right, let's switch gears just a little bit. Same injury, 15-year-old male now. He's a bone age of 15. His MRI shows a typical bone bruise pattern. He's got complete rupture of ACL. He also has lateral meniscus tear. But on exam, I want you to pay attention to this. His motion, he doesn't have full extension. He's only about 30 degrees. He's also completely lax on Lockman. So this is a family that called up, and dad wanted to get on the surgery schedule before he would even make an appointment to be seen. And that's just not how it works. So we got him in pretty quickly. We talked to him, and his first question was, when can we do surgery? And I said, well, hang on a sec. Let's take a look at your child. And, to get those 30 degrees back, that's 2 to 3, maybe 4 weeks of PT. And still didn't really like that. This is an area where I think consistent messaging from other doctors would be very helpful to this family. Now, why do we want to wait on that? When an ACL is torn, and when any really intra-articular injury happens, there's bleeding in the knee. It's almost like a bomb goes off inside the knee. They've done studies that look at ACLs, and it essentially, in that moment when it ruptures, it ages your knee about 30 years, which is significant. And so there's an acute phase reaction. There are inflammatory reactions, and the knee will get very, very stiff if it's not moved initially. And you can make that much worse by going in too soon. So you'll get burned, you'll cause more harm than good by going in too soon. So you want to make sure, one, that they have full motion because they're going to get a little stiff coming out, but two, you want to be far enough out from that initial injury that you're through that acute phase and initial response. So for him, he needed PT. You've got to get the range of motion back, and you want to start working on the quad. The quad atrophies significantly, and the stronger you are going in, the stronger they'll be coming out. And in some patients, it's also to prove that they're willing to do what they're going to have to do afterwards if they want to get a good result. And that's, kind of a case-by-case basis in terms of who am I trying to make jump through hoops to show me they will. And that's just kind of a feeling you get from talking to these families. So how long do you want to wait? Well, you don't want to wait too long. And this is just one of the more recent ones. But a number of papers recently have been talking about how delay is associated with risk of meniscal tears. There used to be a tendency to want to push these things off, let the kids get older, and then we can do more robust fixation. But they're finding that just leads to increased meniscal tears, cartilage degeneration, breakdown, because the knee's not moving the way it normally should, the way it's designed to move. So we don't want to wait too long for that. Another patient, again, 13-year-old football player. He comes in after a non-contact injury. He's had falls. He's had repeated episodes of instability. he's at 2 weeks, he still has his effusion. He's got full extension, but his flexion is not real great. Completely lax on Lockman test. Typical imaging, however, his bone age is 15. So he's nearly skeleton mature, and he looks it too. He's a pretty solid 13-year-old. And his range of motion is improving with physical therapy, but he's still trying to go out and dunk a basketball with his friends. So he's still being a kid. So he had to have the conversation of, hey, the first time to get this to heal is the best time or best chance. And really, you've got to do your part or it's not going to work out. And I've had pretty good results so far. The only 2 times I have had any problems with ACL injuries, I guess, knock on wood, is one, the kid convinced his PT, and I think PT maybe was convinced a little bit by the parents to try to accelerate the rehab protocol. And so they were having him doing jumping drills fairly quickly, which is a huge no-no. And so he stretched out a little bit. He went from solid. All of a sudden, next visit, he was a little bit more lax, still had a good endpoint, but what happened? And so you start doing what he or going through what he had been doing, and that showed you where they had deviated and things like that. The only other one was actually in a young adult, an ACL injury, who was doing physical therapy, was doing fine, was doing his exercises, and then he decided he didn't want to pay for physical therapy anymore, and so looked up exercises on YouTube and started doing those on his own, and unfortunately did too much too soon, too fast. So it really does take 9 months to a year for this graft to be strong, to be as strong as it's going to be, as it was. It takes that long for the muscle to come back, for the neuromuscular firing patterns, the movement patterns to come back. Confidence sometimes takes longer. The confidence in the leg sometimes takes a year and a half, 2 years to come back. So, all right, next thing, I'd mentioned graft incorporation strength. The data really is limited in children. Everything I've been saying is basically extrapolated from the adult literature, but we do know that kids heal faster. They incorporate better and go from there. So takeaways as far as sports injuries, crutches. You got to get the kid off this leg. Initially, a knee brace, either hinge, locking extension, or a knee immobilizer, and then we get them moving. So once the acute kind of swelling starts to go down, we need to get that range of motion back, get the quad strength, and we got to have the conversation that, hey, we do a lot of these every year. We've figured out how to do it right for the most part, and if we follow that pattern and don't deviate from it too much, usually we do pretty well. We do need to get a little more additional information in these kids, bone age particularly, ask about menarche in the girls, see where they are. We try to respect the physis as much as possible, and we don't rush them back. The other thing we're also learning is that prevention programs, all that prehab, all that rehab, working on quad strength really does work. And so when they look at injury rates for ACL injuries particularly, they tend to happen later in games when kids are tired. They tend to happen when at lower levels of flexion. And so what I mean by that is you take someone who's fresh and you have them jump and you watch them land, they will bend those knees pretty well. They'll flex them and they'll absorb that impact and that energy with the muscles rather than the soft tissues. As they get tired, they'll land with less and less knee flexion. And injuries tend to occur at small amounts of knee flexion. And so they get closer and closer to the danger zone, which is normal as you get tired. So if we can strengthen the quad, you can work on some of the conditioning things. It really has shown to be influential in decreasing injury rates. And you can also train people to jump and land differently and in a less risky position. So, all right, let's switch gears a little bit. So rotational deformity, there's a great paper here. It's put out by the Journal of AAOS, so American Academy of Orthopedic Surgery, just rotational deformity. And it's got lots of information on how kids change, how the rotational alignment changes as they grow. one salient point is that really they don't hit their adult alignment until age 8 to 10. And I see a lot of 2-year-olds, 1.5-year-olds for bowed legs, for in-towing. And occasionally, if it's asymmetric or if it's more than physiologic, then we have a discussion. Sometimes at that young age, we'll put them in a brace to try and unload part of the physis and help the leg grow straighter. The vast majority, though, is just a wait and see, and these things almost always resolve on their own. If it doesn't, then I have the parents come back when the kid's older. And this, I think, a lot of this is probably more reassurance to the parents than anything else. When the kids do come back, surgery, or the fix for it, is surgical. There's not a way to derotate a bone or untwist a bone with a cast or with a brace or with anything else. Now, we don't do Forrest Gump braces for the quote unquote normal child anymore. A twister brace to try to correct rotation deformity is really kind of saved for, say, the spina bifida patient who maybe only has the muscles firing that would internally rotate the leg, and all the external rotators are absent, for example. That's the kid who will have a derotation brace because they don't have the balanced muscle firing patterns. And so functional limitations in these kids, if they're tripping and falling down because of the position of their feet or their knees, they're having pain. There's also some social stigma that goes with it. Then we'll have the conversation. But it's a surgery to cut and unspin the bone. And so here's one that we took care of, a 16-year-old female. She's a soccer player, but severe in-towing. She runs down the hall and she about fell in my office, falls, multiple times a day, just can't keep her feet. You look at her and the toes are pointed in. It's fairly significant. When she walks, her patella also face inward. And when you get her on the table, on the exam table, and she's lying face down, so prone position, knees bent to 90 degrees, and then you let the heels fall outward. And as those heels rotate outward, that's internal rotation. And then you cross them, and that's external rotation. So normal range of motion is about 45 to 45. She showed up and she could flop those legs all the way down flat on the table, 90 degrees of internal rotation, and external rotation was almost zero. So her arc of motion was shifted, as this bottom right-hand picture shows, by a good 45 degrees. And x-rays don't show this very well. And so we get a CT rotational profile of here, and we draw an axis down the length of the femoral neck across the back of the distal femurs, and you look at that rotation. For her, that's 65 degrees. Remember, normal is 15. So this is significant. This is severe. And why this makes sense and why you think about this and how it works is the acetabulum, the cup in the pelvis, is your fixed position. So the leg rotates in accordance with that. And so with increased femoral anteversion, which is what she has, to get her toes pointed forward, she has to use the muscles of her hip to externally rotate that femur as best she can. This makes the joint less congruous. And so they'll have pain in the hip and they can't accommodate as well. Now, to put the hip joint itself in a more congruent position, the toes have to be pointed in. Also, you can see the patella pointed forward on the diagram there. If you look at her standing x-ray and you look at the knees, you'll see those patella, they're not in the middle where they should be. They are on the medial side. And that's her rotation speaking. So you discuss risks and benefits to her, and it's a surgery. Now, I'll explain this comment here in just a minute. What we do is, so it's a lateral incision, you in line with the skin, in line with the fibers of the IT band, and you peel up the vastus lateralis, and then you're right on bone and go ahead and make your cut. And then functionally, or I guess logistically, how you do this is it's about like lining up gun sights. You put a pin in the proximal aspect, put a pin in the distal aspect, and then you have these little triangles in surgery that come in 10-degree increments, 10, 20, 30, 40. And so you can see where they are, you mark it, and then you untwist it, the desired amount, which in her is about 40 to 50 degrees on that on that left side. And it was about 5 to 10 degrees less on the right side for her. And it's a bit of a, there you go, pretty close. Okay, lock it in there. It's not a perfect science. It's a bit of a major of the protractor cut with an axe. Now, when she came back for her second post-operative visit, she was doing well. Her mom kind of hesitatingly said to me, her hips, it's like she's a Kardashian. And she got me there for a minute. And I didn't quite know what she meant. She said, well, she's got hips now. What? Oh, okay. And so what happens with these kids is they're not forced to hold those legs externally rotated after you fix them. And so those muscles can relax. And so as you can see in the diagram here on the bottom right, it allows the hips to be more centered, or the femoral head and the acetabulum be more in a congruent position, which is going to increase your profile of the hips a little more. And it is what it is. It's actually put her probably more where she should have been the entire time. And so the hips do become a little more prominent. And that's just one of those things that happens with this, because those muscles can now relax. They're not forced to externally rotate the proximal segment 24/7 anymore. So, okay. Another kid, is 13-year-old male. He has mild CP. His visual acuity is not quite legally blind, but it certainly is decreased. Also has ADHD. His mother, his foster mother describes him as clumsy with frequent falls. And on exam, again, that prone position really is fantastic. Even the little kids, the mom can be staring the kid in the face, can kind of bend down and play with the hands. And often it'll relax the child enough that you can move those legs around and evaluate them. Now his internal rotation was about right on the left side, but it was decreased on the right side. And then when you go to external rotation, he had the opposite. So increased external rotation on the right side relative to the left side. And then his thigh foot angle, the longitudinal axis, when you have that knee bent 90 degrees and you look at the longitudinal axis of the foot relative to the thigh, it was pointing inward by 20 degrees. And so you look at him and you talk to mother, and so you get the CT rotational profile and you explain everything. And she said, but the left leg looks worse. Well, true, it does, because there's only one deformity. On the right leg, though, you had two deformities. You had external rotation deformity of the femur and an internal rotation deformity of the lower leg. And so essentially, they were hiding each other. What really was happening, though, is the knee was out of plane of motion. The knee is a modified hinge joint. And if you take it out of the plane of motion, it doesn't work as well. And so what we proposed was a derotational osteotomy of the femur, but also of bilateral tibias. And so the actual numbers on him, the right, his anteversion normal is about 15. On the right, he was -10. So he's about 25 degrees externally rotated. And tibia torsion normal is about 30. He was -5. So 35 degrees internally rotated. And so it just hit his deformity pretty well. And so you start on the hip, and this is what we did with hip. So same procedure as the last patient on the hip, an osteotomy. And once that's done, it really uncovered the deformity of the tibias. And then same on the, same procedure, small incision down to skin, your kind of medial aspect. So it's basically skin, bone, slide your retractors around to protect it. And then your incision or your osteotomy is perpendicular to the weight-bearing axis. So these kids, once they're fixed structurally, it's actually safe to walk on it. Now, they don't want to because you just cut the bone and it hurt. So you put them in a cast, you protect them and things, but structurally it's safe. Okay. Now he's 13 and had plenty of growth left. And you can kind of see it here at the right proximal femur. There's bone growing over that plate. So we did take the plates out in him. We have not in that prior patient, that 16-year-old girl, because she's done growing. And those plates will not ever need to come out in her. Now, so she can walk down the hall, not trip on her feet now. And this kid as well can too, given the limitations that he already has. So the vision, I can't change that. I can't change the kid not paying attention. I can't change ADHD, but his mechanical falling has ceased. at least as of his last appointment. So the takeaway is one, don't chase a moving target. So they're going to be changing things until they're about 8 to 10 years of age. And once they're done changing, then we can go ahead and put them where they'll be. You don't want to intervene early, because where you leave the leg at age 6 is not where it's going to be at age 16. So, all right, let's switch gears just a little bit. This is now a 15-year-old female that came in with low back pain. She'd had a distal femur fracture several years prior, but had not been followed up. She was done growing 2 years post-menarche. She was otherwise healthy. On physical exam, you look at her, and the ankle bones, the medial malleolus, were not at the same level, about an inch different. And when you bend her up, either on the prone position with the knees flexed 90 degrees, or you just bend the hips, flex them about 45 degrees, 90 degrees at the knees, you'll notice that the femur is the short bone, the tibias are about the same length. Now, because she was actually coming for back pain, we started with an x-ray of her spine, and that's where we saw the hip. Okay, we saw it on exam, but really didn't quite appreciate it, because these kids, sometimes how they hold their legs, sometimes if you're a little swayed to one side or the other side, that can mimic or hide a leg length discrepancy. And sometimes it can be really contracture that can cause it. Hip flexion contracture, for example, or an abduction or adduction contracture can show up as a leg length discrepancy. So you actually have to take a look at the x-rays and measure the bones. And so this is where we saw her. So I asked her, well, how tall are you? She's well, it depends what leg I stand on. So she had character in spades, or personality in spades, I guess, just to say. The recommendation for these, they are kind of old, and they are based on what our limitations were at the time. My personal feeling and what I've observed in other surgeons is that these are changing. They, particularly the shortening versus lengthening. And so when we discuss treatment options with her, she's 5 foot on one leg and 5'1" on the other. And if it was less than 2 centimeters, we don't do anything. We just give them a shoe lift. You can build up the outside of the shoe, and it's not worth the risk of surgery. Between 2 to 5 centimeters, the official recommendations are to shorten. That comes with its own problems, though. As you shorten a leg, you essentially leave the muscles overstretched. So these kids, they get a bigger thigh, for example, if you're shortening the femur. Often you're shortening the good leg. So you're operating on the good leg, not the bad leg that was previously injured. The muscles take some time to get the strength back. They suddenly become a stretched out rubber band, for example. Now, if you're lengthening, that has the opposite problem. These muscles get very, very tight. So physical therapy is necessary. There's a limit to how far you can stretch the vessels and the nerves before you start getting problems. Fortunately, now we have a technology that is allowing this to change a little bit. And so people are being more aggressive with the lengthening at the lower levels. And why this matters is because two things. One, so she already had the back pain, and that can become chronic and degenerative over time. And that's a very hard thing to fix. The other thing is that as the pelvis is tilted, you have the same forces going through both hips. But on the tilted pelvis, the short leg becomes relatively overcovered. It's a ball and socket joint. So if we go back to her x-ray, it doesn't show it real well, but the short leg has more joint surfacing contact and the long leg has less joint surfacing contact. So if you have the same forces, smaller surface area, the pressures are much higher. And so you tend to wear out the long leg much more quickly, and it's documented in the rates of arthritis of the hip. So those are the two reasons why we operate on this when it's needed to. Preoperatively, we get them a shoe lift because, one, you want to know if what you're going to do is going to fix their problem. So this patient got a shoe lift. She wore it. We got them on high dose vitamin D to make sure the bones were strong enough before we were going to do anything. As a side note, about every patient I've sent for vitamin D labs here who has not been supplementing has been low. And I think that's just a function of where we live and lack of sunlight. You also have to talk to the family. So a shortening procedure is much quicker. It's one procedure. You get out. It's a small incision. You cut the bone. You split the bone, and then you put a nail down the rod of it or down the length of the bone, and they can weight bear initially. And you just leave that little bit extra bone in there, and eventually with PT, they get that strength back. Now, you also don't have the risk of stretch injury to the nerves and the vessels. But if you can imagine, there's a limitation to how much you can shorten something, just like there is to lengthen. And it doesn't work quite as well in the tibia because the fascial compartments are a little more confined, a little more restricted. And so it's probably a little more suited, better suited, I think, for the femur. And then this is also one that this is not a heart attack, it's not cancer. And I actually say those words to the families. This is not something we have to do. Your life is not dependent upon this. So I don't run any risk with these patients. I make them prove to me that they are willing to do the therapy they're going to have to do afterwards. They want to get a good result. So this is her preoperative planning radiograph. Standing long leg alignment. She's got a block under the left heel. You can see the tibias are fairly equal. There's about 31 millimeters difference at the femurs. And so what do you want to do? She's 5 foot or 5'1", depending on which leg she stands on. She's skeletally mature. What do you want to do? Well, to lengthen or shorten. So I'm 6'7". I have a hard time telling people that being tall is not that great. I hit my head on a lot of things. But this is a picture of Muggsy Bogues and Manute Bol, both the tallest and shortest basketball players in the NBA. And they were on the same team at one point. This was in the early 80s. Anyways, so for her, she really wanted to lengthen. Against her parents' wishes, they talked about it, and they said, okay, go for it. So this is her immediate post-operative radiographs. This is what's called a precise nail, and it's a motorized lengthening nail. It has electromagnet in it, and so there's a machine you put on the outside of the leg. There's a mark you place on the skin. It's centered over the magnet, and you turn it on, and it takes about 30 seconds to a minute. You do that 4 times a day, and you lengthen by 1 millimeter a day. So she lengthened 4 times a day, every day for a month, and that gave her that gave her the length that she needed. So as they do this, you can't have them put weight on the leg. So she was on crutches and she got in stretching. Now the complication rate with lengthening is about 150%. So you tell parents it's not a matter of if, it's a matter of when. And so you do monitor these kids closely. Now this is a reason why this is, I think, something that is best done near the treating surgeon. So I saw this patient weekly. This would be a hard thing to do from a distance. And so this is a kid that I think needs to stay in Alaska for this, for example. This isn't, special needs child. She's otherwise healthy. There's no need for this to travel out of state for the family, for example, as I mentioned previously. Now, by the end of her lengthening, you can see she's longer. You can see she's made new bone. And this is the stage where we started letting her put weight on it. And so typically it's about a millimeter a day. And the recommendations for adults, at least, is another month off or non-weight bearing on the leg for every centimeter that you lengthen. So for her, the recommendations would have been 3 months once you're done lengthening of non-weight bearing. Well, at 2 months, being a kid, she had made so much bone that we could let her put weight on it. The nice thing too about kids is they always do a little more than we allow them to do. And so when you ask, are you putting weight on it? And they kind of sheepishly say, no, not really. But they've been hobbling to the bathroom, putting weight on it and things like that. And so that lets you know that, hey, it's safe to let them go. Now, we don't let them go back to sports or anything yet. And this rod will have to come out eventually, usually about a year to year and a half after. Complications. So her complication was that as we lengthened her, and this happens about 10% of people, is the common perineal nerve as it wraps around the head of the fibula started to get pressure. So she began to have some numbness and tingling on the outside of her lower leg, the lateral aspect down in the foot. She did not have any muscle weakness, but we saw it. We stopped lengthening for about a week to see if it would go away. It did not. So we went back to surgically, and it's just you're snipping these little fascial bands that overlie the nerve as it wraps around, and then that numbness and tingling went away. Some people do that prophylactically. You know, the numbers are 10 to 15%, so I'm not going to do that every single time. I'll do it on an as-needed basis. Now, we can do this with tibias as well. So next patient, 15-year-old male, he's a clubfoot patient. So he's had Ponseti casting, multiple surgeries, and he's skeletally mature with a 3-centimeter leg length discrepancy. So the questions you have to ask, you know, we're still in that, do you the official recommendation is to shorten. Do you shorten? Do you lengthen? Well, do you want to shorten a good leg that's never been operated on? Or do you want to try and lengthen a leg that you know the muscle is always going to be a little bit tighter, a little underdeveloped, the foot's already a little stiff? And so this is a conversation you have to have with the family. And it's a case-by-case decision. For him, we opted to lengthen. And these are his x-rays at the time we went back to take the hardware out of his ankle. You can see there's a screw from his calcaneus to his distal tibia. And that's because these kids get really, really stiff and they end up in an equinus contraction. So they're in PT, they're stretching, but we actually fixed the joint so it can't develop an equinus contracture. And so we got that screw out. We took out the screws between the fibula and the tibia, both proximally and distally. And now he's weight bearing on this. You can see he's been pretty compliant, because if you look at the distal aspect of these x-rays, you can see the osteopenia. And that's a sign to me he's doing everything he should be doing. He's doing everything right. And the body's behaving as it should. So his complication was actually fairly minor. He fell initially right after he went home. Fell getting in the shower that very first time. But fortunately, things were stable. Nothing shifted out of place. And he's making pretty good regenerate bone here. And so again, we're letting weight bear continue the vitamin D. And that impact, that loading of the bone will help this thing solidify out. Now that screw, in case you're wondering, is actually outside the joint between the calcaneus and the tibia. So it's not actually going through any cartilage, it's not destroying the joint. And so you get that out, and they're a little stiff, but it's under general anesthesia. So you can manipulate the ankle a little bit, get some of that motion back, and then get them moving, get them into PT. And so he's doing well. And so we can do this here in Alaska safely. Now, those were two skeletally mature children, young adults. I guess they'd probably wouldn't mind me calling them children. In a kid with open growth plates, open physes, we can do what's called growth modulation. And this is much less invasive. And so you can put a little bracket on both sides of the growth plates to slow things down. And it's really quite a bit shorter recovery time. You do have to monitor, because you're often trying to slow down if it's overgrowth and a more rapidly growing leg, and you're waiting for maybe not as healthy of a physis to catch up. So it's harder to predict exactly how long or what time frame it'll be in for. But you avoid that shortening, you avoid that extra redundant tissue or that over tightening of lengthening or shortening. It is, however, though, not as precise. It's harder to predict where these kids will be in terms of their growth, their maturation, how much growth you have left. And there's also a little bit of lag time as the growth plate grows and then tensions at. It tends to be about 3 months. And so you have to factor that into your calculations. Now, here's a child I saw yesterday. So 18-month-old female came in for leg length discrepancy. She's meeting all her milestones, otherwise healthy, but has a significant leg length discrepancy, particularly for her age. And this is 3.5 centimeters. Now, if you look at these bones, they're not healthy either, especially if you look at the distal femur and the proximal tibia on the left side. You look at the distal tibia on the left side. But if you look closely, you'll see smaller but lesser versions of this at the hip joint bilaterally and at the right knee, both femur and tibia. Now, what it looks like is that bits of the growth plate got left behind. And so you see those tracks. Now, I don't know what this is for sure, but it looks for all the world like some type of enchondromatosis. And so you're thinking, OLIAs, or maybe even Mafuchi's, which is basically multiple enchondromatosis with hemangiomas as well. And so this is a big deal. Enchondromatosis is associated with chondrosarcoma. The rates are fairly high. If it's Mafuchi's with the hemangiomas as well, then you're looking at visceral organ tumors as well. And so we're going to get her in genetics, and we're going to figure out what this is. But this is a big deal in this child. And so the tumor will, that will take precedence. But eventually, we'll have to figure out what we're going to do with her as far as leg length discrepancy. There's nothing to do now at this age, way too young. But it will probably be something similar to this child. This is a 6-year-old female with neurofibromatosis, worsening leg length discrepancy. So while you'd like to not operate during this kind of 5 to 10 year window when growth is fairly uniform, fairly static, it just moves along at a predictable, reliable rate, you don't want things to get out of the realm of possibilities. And so she will probably need a combination procedure. We're going to shorten the long leg now by those brackets that I showed you previously, and we'll let things equal out, and that'll take several years. And then we'll remove them. And then when she's all done, she'll probably need a lengthening procedure to equalize, and we'll be able to get her bang on that way. But the goal is to stay within striking distance. So takeaways is timing really is everything. You have to individualize to the patient. Now, if they have a large leg discrepancy and it's static and there's lots of growth remaining, you've got time. But if it's getting worse, you've got to move on it. Now, one of these things is if your patient has a growth plate injury, the fascia got injured in a fracture, an infection, tumor, we've got to follow these kids. Otherwise, for example, that first one I showed you, the 16-year-old with the 2.5, nearly 3 centimeters distal femur, that was after a fracture. We could have done a much less invasive procedure. It would have left her shorter, but it would have been much less invasive and would have saved that back pain and everything else if we had been able to get to it sooner. All right, how are we doing on time? So I can jump here to scoliosis and AT, or we're kind of a natural break point. We're about at an hour. If someone wants to chime in and say what they want to do. Anna.
Oh, Anna had to go do patient care. This is Jody.
Okay.
Hi. There's we have a couple of questions, so
Well, why don't we answer the questions and then we can save the rest for another time or something.
Okay, great. Okay. Oh, wait a minute. Chat. Okay. Dr. Chandler has a question about recommendations for sports restrictions after a fully recovered ACL repair. So if you could talk a little bit more about ACLs.
Okay. So ACL repair, reconstruction. So one, you got to get the quad strength back. So something I have them do is a single-legged squat in the clinic. And if they can do 10 of those, if they can jump, and things you're looking for with that, you want to look as they squat, you want to see what their knee control is. Does the knee drift towards the inside or fall towards the middle? Are they able to get all the way down, all the way up? You're looking for symmetry of the quad. Is it coming back? And so if they can do the squats, then you can do single-legged jumping and see how they're doing. Once they're there, then it's kind of a sport specific. You take them out, soccer players, you're having them do the ball handling, you're having them do cutting, you're having them do sprints. Similar to football players, you start doing the cutting drills. And if they can do that, if they've got the strength, and then you take them to the functional, and they can do that. And that can be done with, if you know the athletic trainer and they're familiar with it, that's one option. The other option is PT, someone who's familiar with this. They can do that. The other is just timing. Is I don't let kids go back before 9 months. Everyone wants to get back sooner, but it takes time for that graft and for those collagen fibers to be just as strong and just as robust and organized in the right way as it needs to be. So it's kind of a gestalt. When you see these kids, you realize, okay, they can do a squat, they've got good strength. Okay, let's try the jumping. They still have the control. They're not tiring out, and then you can start trying the cutting. So it's fairly static, then a little more dynamic, and then or inline, and then it's the change in directions, because that's where it's at risk.
Great.
Once they get your blessing, they're good to go with all sports?
Yeah, once we clear them for sports, we let them go. It's one of those things, though, you have to talk to the parents, talk to the patient, because confidence, and that's the last thing, that's going to take 1.5 to 2 years. Neuromuscular firing patterns come back before that. The strength is back before that. But once they're cleared, we let them go. So the caveat being is about 70% of ACL injuries are a non-contact mechanism. The kid plants the leg, cuts, twists, pop, there it goes. Now, once you've had one ACL injury, you're about 50% more likely to tear your ACL again. However, it's about split 50-50 between the previously injured leg and the contralateral uninjured leg. So there's something about these kids, either anatomy or strength or movement patterns, that sets them up for that.
Thank you.
You just have that conversation with the family.
Great. Okay. Don't forget to, in the chat box, you can also see the link to get your CME. I want to thank Dr. Brown very much. This was very, very interesting, and I'm sure we all learned something and more things to look at. Dale, do we have any other announcements for AAP?
We don't. Just a reminder that folks can watch this program as well as all of our other Grand Round programs from our aapalaska.com website.
Great. And is there Grand Rounds next week, or is this the last one?
This is our last one until the fall, and I will be
Okay.
sending out the entire schedule for the fall season sometime later this month.
Oh, great. So it's time for summer break, if you will. Anyway, thank you again, Dr. Brown, and thank you to everybody that participated, and we will see you next fall.
My pleasure. Thank you, guys.